Great. So I'll start by talking about what is implementation science and why do we need it. Then I'll spend a few minutes going over some key concepts, 3 or 4 key concepts that I would like you to try to absorb and that we'll come back to throughout the course this week. Then I'll spend some time talking about frameworks, which are a very important aspect of implementation science and some of the key methods. And then I'll address some myths and misconceptions before concluding by talking about the importance and impact of implementation science. So let's get started with what is implementation science. So we know that implementation science or innovations are always in the news, at least in the US, and I imagine it's the same in Georgia. We're always being told about what medicine can offer us. But unfortunately, those are not always followed through when we go to the hospital or the public health clinic. Here's just a few examples of amazing innovations from 2023. But I hearken back to an article in the Washington Post from about 15 years ago, where they talked about unhealthy medicine, all breakthrough, no follow through. And this is not something that's confined to public health or medicine. In many other fields, people struggle to address this no-do gap. This is a famous book by business school professors who talk about how it's an aspect of human nature that we just don't do sometimes what we know we need to do. And we know that that has a huge impact on this promise of innovation. This is a famous diagram that appears in probably almost every textbook on implementation science, and every talk wouldn't be complete without talking about the gap that exists, the 17 years that it takes for innovations to move from basic research to actually being put into practice. And along that way, we have this funnel type situation where we lose a lot of the insights and innovations. Those are just lost along the way. And there's understandable reasons for that. As researchers, we're often starting about here at the beginning, trying to come up with a good idea, and we have to pass through the narrow funnel of the peer review process to get funded. We have to deal with publication priorities of journal editors and reviewers. That creates delays. And then even once a seminal publication is published, we need to see that result replicated to make sure that the findings are rigorous and reproducible. Those findings need to be synthesized by guideline bodies, put out into guidelines, and only then can we start to think about those getting out into practice and being adopted. And so what are we doing with implementation science? What's the reason for it? Well, the latest research really shows that we should do something with all this research. So this is making fun of us as researchers sitting around the table, looking important with lots of papers in front of us, perhaps trying to synthesize this evidence to be used. But beyond that, there's a real gap, and a real serious gap that's not a joke at all, that our patients who could benefit from some of these life-saving innovations can't get access to them. So let's start with a little bit of a definition. Implementation science is the scientific study of methods to promote the systematic uptake of research findings and evidence-based practices into routine or real-world practice. So I want to just kind of highlight 3 aspects of this definition. The first is that evidence-based practices are the basis of what we're doing in implementation science. So we can't move forward without having some idea that what we're wanting to use, these innovations, can actually be the basis of what we're trying to introduce. Second, implementation science is about systematic uptake of these research findings. So really, we want to have an impact, whether that's on the field of HIV and people living with HIV, whether that's on people living with opiate use disorder and wanting to use those, or any of the other many diseases where there's big gaps between evidence and practice. Then I think the final big point that I'd like to mention is that implementation science is not only about solving a particular problem in a particular field. There's a bigger ambition here. The idea is that we would take learnings from one field and apply them in other areas. And so to that extent, as people interested in implementation science, we want to advance the methods of this field. It's a young field, and a lot of times you're going to find that there isn't a method sometimes to do that. And that's why having colleagues like Denise Esserman, who has expertise in methods, or my colleague Ashley Hageman, who you'll hear about a little bit later, who has expertise in qualitative methods, can be very helpful. I think I've lost my ability to advance. I'll just step over here. So just to highlight those 3 aspects. Okay, so what is implementation science and why do we need it? Now we can move forward to kind of talking about some of the key concepts. So I want to tell you a little story about a guy named Everett Rogers who wrote a book called The Fusion of Innovations. Now, Everett Rogers grew up on a farm in Iowa in the middle of America in the 1930s and 40s and 50s. And at that time, farming in the US and around the world was undergoing a rapid evolution. Lots of new technologies were coming into farming. There were fertilizers, there were the development of mechanized tractors and other devices to be able to harvest the crops. And there were also innovations in terms of genetic modifications of crops to be more resistant to drought and other challenges and to get higher yields. And growing up in Iowa, there was a seminal point in the late 1930s when a drought came through. And Everett Rogers' father was a farmer, and he was open to some innovations such as the mechanization, but he was more skeptical of some of these hybrid corn crops. And there, in the midst of this drought, Everett Rogers could look out on his father's field and see that the corn was all dying where the neighbor's farm was surviving. And so that was kind of curious to him. So in the 1950s, he pursued a sociology degree at the University of Iowa. And he described this process of how people adopt innovations that's probably very familiar to many of you in the room. This idea that there's a normal distribution of people who some of them are very used to or very anxious to adopt new technologies, whether those are mobile phones or maybe these are new technologies for treating patients with particular health disorders. Whereas the most of us will probably wait to see those few innovators, what kinds of success they have. And there may be a few people who are the laggards. They'll wait till the last possible minute to adopt something new. And more than just knowing that the population has this distribution and the uptake of innovations would adopt in this sigmoidal curve, Rogers also wanted to try to understand what are some of the characteristics of innovations, which are shown here, their relative advantage, their compatibility, their complexity, their trialability, the ability to observe change. All these factors which differ from innovation to innovation may affect people's interest and willingness to adopt them. And if we understand those, it can help us design strategies to help promote that uptake. And you'll see that this diffusion of innovations carries through in a lot of the theories, models, and frameworks that we began to use later. So a key concept that comes out of the diffusion of innovations developed a few decades later, after the diffusion of innovations had made its way through business and many other fields. Finally, healthcare caught on in the early 2000s. And I'll take you to the United Kingdom, where the National Health Service was experiencing a lot of crises. And the National Health Service asked a group of academics to undertake a review of all the literature, looking at sociology, engineering, psychology, and many other fields of quality improvement to try to understand what were some of the common ideas of how innovations could be taken up and adopted in healthcare. And one of the principles that came out of this is that often we rely on diffusion. Diffusion meaning just watching something happen. This idea that I showed you a few minutes ago of the funnel, that if we just publish an article in a well-reviewed journal, if we give a talk about it, then we assume that people will adopt that. But we know that it's more complicated than that. You need some active elements of dissemination to try to help it happen. You may need experts to come and share their experiences, spend time in the clinic, think about what types of programs and policies need to be developed. But in implementation science, really what we would like to do is accelerate that process and make it happen so that the transition to evidence to practice is not left to chance, but it's actually something that we can make happen. So a second concept is that implementation science is one of the translational sciences. Now, often in medical schools, there's this elevation of traditional translational science where people take basic science concepts, whether those are related to cellular observations, molecular physiology, or gene editing, and translating those into new therapies. Those are the things that we always read about in the news. Moving from basic ideas, so-called translational type 0, translating those to humans, eventually translating those to patients. But at the far end of the spectrum, there's also a type of translational research called translational type 3 or translational type 4, which is really the domain of implementation science. So once we've generated this evidence, once we've proved the concept, we also need a science that's going to allow us to translate that and move it forward. And I'll talk a little bit later about some of the people that are key to making that happen. But for now, I'd like to just highlight that this is not necessarily something new. We know about this in terms of drugs and devices. Drugs and devices have a very standardized approach. This is the way that it's done in the US, that we move from phase 1 up to phase 3 trials, clinical trials to develop new innovations. But we need to think about the same type of process, and it needs not only to be linear, moving from left to right, but it needs to be iterative, because a lot of times we're not only wanting to translate new ideas into practice, but we want to learn about what's not working in practice so we can come back and make our therapies and innovations more effective. So I'd like to take a little bit of a slight detour for a minute, because I've been talking a lot about theory and big ideas, and I want to give an example of how this translational process works for something that is one of the greatest public health successes of the last 30 years, which is the development of HIV treatment and subsequently moving it from a therapy for individuals to an approach that is effective for populations. And that started out around 2007 or so with modeling of the idea of treatment as prevention. So the idea here was that by giving antiretroviral therapy, we could not only drive down the viral load of an individual, but by doing that, we could decrease the risk of that individual transmitting HIV to other people, because if they did have transmission opportunities, whatever those might be, shared needle exchange, sexual transmission, that with a lower viral load, that transmission was less likely to happen. And as is often the case, people wanted to try to see if that idea would work. And in the context of implementation science, that may not necessarily be in a laboratory with animals or mice or cells, but in a modeling laboratory. And Ruben Granich and colleagues looked at the impact of different strategies for initiating antiretroviral therapy, their impact on incidence and on mortality. And the standard approach was to just continue without any intervention. That's the red line that you can see. And you can see that that was associated with very high sustained incidence and high mortality. A second opportunity was to only initiate antiretroviral therapy when the CD4 count was less than 350, the blue line. And that had huge impacts on mortality because it would get people early on. But this idea of universal voluntary HIV testing and immediate ART, that was the one that would really drive down incidence and potentially transmission. So then that led to translational type 2 studies to try to answer the question, can ART prevent HIV infection? So in 2011, Cohen and colleagues undertook a phase 3 trial that looked at partners that had different HIV statuses, and tried to see whether if you started people immediately on antiretroviral therapy, could you decrease those transmission events? And wow, talk about an effective intervention. I mean, how many interventions are there that reduce the risk of transmission by 96%? I love this study because when you look at the Kaplan-Meier curve, it was so close, the event rate was so close to zero that they had to blow it up to be able to show the difference between those two. So 96% effective. So this is an effectiveness trial, translational type 2 study, showing that ART can prevent infection. But this is just individually or a cluster randomized trial at the level of discordant couples. So now we need to try to think about whether this can work at a population level, translational type 3, from the bench to the bedside, from the bedside to the community now. How can we get this out? And there were a number of very large trials that were done in different communities around the world, primarily in Southern Africa, to look at this idea of universal test and treat. These were effectiveness trials to try to see if at different thresholds, as ART became more available, could we have a big impact? And you can see across all these studies, by initiating ART earlier, we dramatically decreased the proportion of people who had undetectable, increased the proportion with undetectable viral loads, and had an impact on the effectiveness of ART care. Okay, so 17 years later, though, I mean, this is one of the best successes. It took 17 years to get here, even for HIV, with all the funding, community engagement, and everything else. And so the question is, how do we now think about moving from evidence, translational type 3, to type 4, where this is universally adopted? So I'll come back to that and I'll answer the question later, but I want to get back to kind of key concept 3. Key concept 3 is that we must be able to measure implementation. Now, traditionally, when we do a randomized trial, will receive the result published or presented at a conference, and it'll either be positive or negative. And the presenter will say the P was not less than 0.05, or it was less than 0.05, or there was no difference, or there was a difference, and people move on. But that to me has always seemed a little bit strange. I mean, aren't we actually interested in what happened inside the trial? It's almost like we put a big black box over it and nobody knows what happened inside. I mean, did people take the medication? Did the device work as it was supposed to? Did this behavioral intervention, did it actually change some of the factors that we wanted it to change, whether that was motivation or people's knowledge or the opportunity that they had to engage in care? Because if we don't make these measurements, if the trial fails, then we won't know we won't know why it failed, and if it does work, we won't know how. So we really need to look inside this black box to kind of get an answer to that question. And the way that we do that is something called a process evaluation. I'll talk a little bit later about what are some of the methods for doing it, but first let's get the concept across. So here you still see there's an evidence-based innovation, and innovation is a therapy, a device, a set of behavioral interventions that tries to have an impact on some health outcome. What we're also interested in inside is how well was that innovation actually delivered? So were people able to come to the clinic on a timely basis? Was the care that they received patient-centered or person-centered? Was it efficient? Was it cost-effective? Was it safe? These are some of the things that we want to know about evidence-based interventions or innovations or practices. But we also need to know whether the implementation outcomes were working as well. And we'll talk about what some of those implementation outcomes are in a minute, but how well that works may depend on the strategy that we use to introduce it. And the answer to those questions is in something called implementation outcomes. There's a paper that probably will come up a lot during this course that was written around 2011 by Proctor and colleagues that laid out this framework called the Implementation Outcomes Framework. And it's kind of highlighting some of these outcomes that we often don't measure. We may only look at mortality or satisfaction or function or health symptoms. But by looking at these more proximal outcomes of service, so how was the innovation delivered? How was the evidence-based intervention delivered? And then also understanding whether the strategy that we delivered it by was acceptable, was it appropriate for a particular setting? Was it feasible? Did people or clinics actually adopt it? Even though we did the training, when we went away, did they actually offer that to the people living with the disease or at risk for the disease? Did they do it with high fidelity, meaning that did they adhere to the protocol as was laid out, or did they adapt that in some way? And then if we go back over time, did they continue to use it? Did it actually penetrate into the culture of the clinic? We also might want to know something about the costs and the sustainability. Okay, so with those key concepts kind of gotten across, the idea that we have to advance innovation, we need to move it forward using implementation strategies, that we need to be able to kind of measure how that actually happens by measuring implementation outcomes, and that we do that using a translational process. Now let's talk a little bit more about what are some of the frameworks and methods that can allow us to do that. Now, theories, models, and frameworks are probably one of the scariest topics for anybody who has approached implementation science. I have a book that I haven't read, but I like to show sometimes that lists 200 different theories, models, and frameworks that have been developed to try to change human behavior. You know, there was a point, I think, in implementation science where if you wanted to become a professor or get promoted as a professor, you needed to invent your own theory, model, or framework. Fortunately, now we're moving beyond that, and we're really trying to think about which ones work. So I'm going to talk to you about one or two theories, models, and frameworks. I've already talked about the Proctor framework. I'm going to talk about one other in just a moment. But I want you to understand that these are here to try to help you make sense of a busy landscape that includes lots of different terminology and lots of different outcomes and predictors. And this comes from a paper by Nilsson and colleagues, which I think is the most cited paper in the journal Implementation Science of all time. And really what it shows is that you might want to think about different phases of implementation. There's the planning phase, the implementation phase, where we're actually introducing things, and there's the evaluation phase. And for each of these, we've got some different theoretical approaches that can help us. For planning, we have process models. Process models just help us understand that there's a set of steps that we're going to follow to carry out an implementation science project. A lot of times in the class that I teach, people want to start at the end and develop the strategy. And I have to say, no, you need to go forward step by step. And we're going to talk in just the next few minutes what those steps are. Second is, once you get to implementation, there's a variety of different approaches that you might want to use depending on the type of intervention. Determinant frameworks, which include things like the consolidated framework for implementation research, help us get the overall landscape to understand what are the barriers and facilitators to implementing evidence-based practices. Classic theories tend to deal with human behavior, the theory of planned behavior or the health belief model. What is keeping me back from actually engaging in care? So those can be very good for individual type interventions. And then implementation theories are an exciting new area that's developed. We don't really know that much about it, but the idea is that we can use these theories to come up with strategies that actually can work to close the evidence practice gaps. And then finally, there are the evaluation frameworks that help us at the end, after we've collected all this data, to synthesize it in some way that it actually makes sense and that hopefully can be applicable to other types of problems. So step one in the process model of implementation science is that we have to start with the people who are on the front lines, the people living with the disease and the people that are caring for those people, whether they're the caregivers or the frontline practitioners who are doing the screening, diagnosis, and treatment. And there's a concept called the social ecological model, which is going to be carrying through all the theories and models and frameworks that I'm talking about today, which understands that we as individuals are part of a larger whole. We're part of our households, we're part of our communities, we're part of health systems when we seek care, and we're part of larger societies. And at each level, there may be factors that affect the type of care that we can get. So, but before we get to that, we need to talk to people at each of those levels, potentially as implementers, to try to understand what's needed. So patients, practitioners, and people. Health systems may involve hospitals and practices, health departments, and principal investigators. And at the high level, when we think about policy, they're policymakers, they're the people that pay for care, and they're the people that develop the new products, whether those are drugs or devices that help make us forward. So engaging with those people to understand, oftentimes in settings like this. I borrowed this slide from Rick and Lynn from a training that they did where they engaged the community, try to understand what were the barriers and how could they change things. And this is another type of setting in a clinic. So second, once we've engaged those stakeholders, we want to figure out whether they're actually ready to move forward before we start implementation. There can be a lot of reasons why people might or might not be ready. And the consolidated framework for implementation research is one of the most powerful tools that we have in implementation science. It was first described back in 2008, and it's recently been updated in 2022 based on how people use things. Now, what I'd like to highlight for you is that this consolidated framework for implementation research, it's not entirely new. It really builds on this concept of diffusion of innovations. A lot of the same ideas that Everett Rogers discovered and wrote about over 70 years ago now come through in the modern consolidated framework for individuals. So of course, we're going to start with the characteristics of intervention. Remember Rogers thinking about, is this something we can easily adopt? Is it compatible with our existing infrastructure? Is that we can try out and make sure that we like it before we use it? Those are the same characteristics expanded a bit under intervention characteristics. So we always want to think about that when we introduce, whether it's PrEP or opiate agonist therapy, or just simply medications for hypertension. Any of those things, we'd want to think about what are the characteristics that are going to affect the processes that we use to implement. Now, process is going to be drawing on some of those same concepts that the Proctor framework talked about and that I mentioned already. There's also the characteristics of individuals, drawing a lot on some of the traditional theories of classic theories of behavior. And then there's the inner setting, the characteristics of a clinic, how it works, who is in charge, what are the resources that are existing in that clinic. And the outer setting has to do with the policy and payer and change environment that I talked about earlier. So the methods that we're going to use to explore this oftentimes are qualitative and sometimes mixed methods. And qualitative methods you'll hear more about from Ashley Hageman a little bit later, but they have a lot of different uses. They may help us engage stakeholders, as I talked about a few minutes ago. They may help us identify barriers and facilitators, figure out readiness for implementation, tailor strategies so they, and interventions that they work in local settings, and evaluate implementation processes. So I'd like to show you in the next slide an example of a way that we use the Consolidated Framework for Implementation Research to conduct a parallel convergent mixed method study in which we surveyed practitioners and also did interviews prior to introducing a new intervention for finding undiagnosed TB cases. This was in sub-Saharan Africa. And what you can see, this is nicely put together by one of our students, Ann Johnson. And what she was able to do is pick specific questions that kind of mapped onto the Consolidated Framework for Implementation Research. So asking people, do you go to other parts of the clinic to get educational information about tuberculosis? Do you get training and support from implementation partners, and so on and so forth? And those are mapping to different aspects of the Consolidated Framework for Implementation Research, from the outer setting, which is shown in red or orange. We've got elements of process. We have elements of the inner setting. And then we also used a survey at the right-hand side to figure out whether the resources were available to conduct each aspect of the evidence-based intervention that we wanted to introduce. So just an example of how you combine qualitative and quantitative research. And I'll just go back for a second to the previous slide. The cfrguide.org is something you may want to check out to kind of see how you could come up with those questions. So once we figured out what some of the barriers are and some of the facilitators using CFR, we can also think about using strategies to do something called implementation mapping. So implementation mapping is a process by which we start out with the problems that are preventing care from being delivered. So we may want to figure out where those are happening and why they are happening. So what are the causes? Once we know that, there's an emerging body of evidence that suggests that we can now pick among a category of strategies. And these have been categorized in something called the expert recommendations for implementing change or ERIC. You can see here, we have examples of engaging consumers, use evaluation and evaluative and iterative strategies. We can change the infrastructure in a setting, maybe adapt and can tailor the intervention to the local context, so on and so forth. These strategies can be mapped actually to the types of barriers that we identify. And we could talk more later about how that's done, but ultimately implementation mapping is going to help us choose strategies that fit the problems that we're trying to solve. And I'll give an example of that in just a moment. So 5 minutes, yeah. So implementation mapping in Uganda in 2013. So this is an example of how, in terms of trying to scale up this prevention strategy, this ART strategy, the providers identified barriers which existed. So there was a lack of knowledge about early start of ART. There was a need for multiple visits to get counseling before starting ART. There was a need for CD4 counts, and then there was kind of a lack of motivation to make all this change. And so specific interventions to address those barriers were introduced, including an opinion leader, teaching and coaching, a revised counseling protocol, a rapid CD4 count testing service, and feedback to clinics. And with these 4 interventions, they sought to address these 4 barriers. And then they conducted
Next, it's important to choose a study design for implementation and evaluation.
So here is an example with the streamlined ART trial. And what you can see is that the red line is the intervention group, the green line is the control group, on the y-axis is the time to getting on ART. And what you can see is that from the start, about 70% of people were adherent with this goal of getting people started with 2 weeks, versus less than 20% in the control group. And even more, this benefit was sustained over time. So they started out in 2013, down below 60%. And then when they got up to 80%, they were able to maintain that. And it was similar across all of the different clinics. So I want to just kind of close by talking about a few myths and misconceptions. and then talking about the value and impact of implementation science. So the things I most often hear are, A, I don't know anything about implementation science. B, implementation science is not a science. And C, it's too early to think about implementation. Now, I just want to reassure you that even if you have never heard of implementation science, you probably know something about one of the disciplines up here on this slide. And really, implementation science seeks to kind of take the traditional groups that address health, the clinical sciences shown in the upper right, the population sciences at the lower right, so epidemiology, biostatistics, and marry them to other sciences that are often excluded from health. The social sciences, including anthropology, economics, psychology, and sociology, and the engineering sciences, which include computer science, logistics, operations, and management. Implementation science doesn't necessarily need all these groups, but these intersections are often very, very productive in terms of addressing problems, either designing strategies that address behaviors, lower costs, or coming up with new technologies that can help us do things better than we did in the past. Second, implementation science is actually a science, and it exists on a complex landscape. Just because of time, I won't go into detail here, but a lot of times people may ask, what's the difference between implementation science and quality improvement, or implementation science and operational research? And really what I want to try to say is that it's about generating new knowledge and disseminating that knowledge about how do we change a problem. It's not just solving one particular problem that you have with one specific type of intervention, but coming up with general strategies. And I think you're going to hear a lot about that, especially as Lynn and Rick talk about generalizing approaches for putting people together to solve problems. And that once groups get together to solve one type of problem, then there's often a powerful approach with implementation science to be able to solve many problems. And then third, sometimes people say it's too early to think about implementation. Now, we talked about process models and different stages of implementation science. This idea that we move from translational type 0 to translational type 4 research. And it's true that maybe early on we want to try to understand, is there a relationship? Do we have an approach here? Can delivering universal ART decrease HIV transmission? Then we may move to these efficacy studies at household level, then the effectiveness studies at population level before we ever get to the implementation studies. But we really want to be thinking from the beginning, could this be a feasible, acceptable, and appropriate type of intervention? And when we design our studies, maybe be as pragmatic as possible about who we include and how we deliver these strategies so that we'll know something at the end. And then third, we can try something which is something called hybrid implementation effectiveness studies, where we look at both types of outcomes. Does it decrease a viral load? Does it improve CD4 count? Does it increase survival? But also, are people able to deliver this intervention at population level so that all can benefit? So I'll just close by saying that traditionally we think about clinical and public health research in terms of efficacy and effectiveness. And we may be obsessed with particular types of study designs like the randomized trial. And this is a quote from Donald Berwick, who founded the Institute for Healthcare Improvement and has thought a lot about how do we actually improve and implement evidence-based interventions. And he says that where is the randomized trial is for many purposes the right question, but for many others, it's the wrong question, a short-sighted one. A better one is broader. What is everyone learning? And so let's try to take this forward as we go through this course today to think about what does a learning health system look like, where we systematically gather and create evidence and apply the most promising evidence to improve care. So looking forward to being with you this week. Please approach me if you have questions. It's quite daunting to absorb all of these concepts at once, but together we can move up and see the heights of the city and learn from each other. And I thank you for the opportunity to be here. So I think we might have maybe 5 minutes or so for some questions.
Oh, yeah. Thank you so much for this brilliant lecture. This is the quite task to bring the concept of implementation science to the auditorium in 35 minutes, and you did that. So thank you so much for that. I'm stealing 5 minutes from Rick's time. So perhaps you have some questions and or comments or some associations and could share with us. Please be informal, be proactive.
Microphone is available here. You just, indicate that you have questions.
Thank you for a very interesting presentation. And my
Could
question,
introduce yourself.
I'm Mari from Yale State University, and I have a question which might take lots of discussion, but what are the main challenges to change mindset during implementation science? Like people are kind of insecure to adapt new things, and what are the main challenges which you have during this process?
It's a great question. Thank you so much. I think that there are three main challenges. The first of all is that this process takes time, so you need to be patient. You want to be impatient in the sense that you want to be moving forward, but you also have to give people a chance to get their ideas around what you're proposing. And that's really the concept of community engagement. Listening to the community to understand, is the community ready? Because if you push too far, you're not going to get anywhere. You need to move at the pace and try to accelerate that pace over time. And that engagement of the community, finding an ally who you can build trust with and really listen to people telling, that's the number one thing. The second thing I think is that you need a sort of framework for approaching things. And I've talked about a few different frameworks. I think the consolidated framework for implementation research can be really, really useful for understanding what level the barriers are. And then I think thinking about what are the types of strategies that may actually be helpful in tailoring those to those strategies. In teaching my course over the last 7 or 8 years, I find that every single group, their number one thing they want to do is education, and they assume that every problem is because people don't know. And what I found in my work is most of the time is that people actually do know, but they can't actually take advantage of that knowledge. And so you need to understand what are the opportunities or barriers that exist: lack of time, lack of resources, structures that don't allow you to deliver care. And you need to help motivate people by picking small goals that they can achieve and get confidence in what they're doing. And once you get them going, you won't be able to stop them.
Perhaps one more question, or should we proceed?
See if we can hear from Rick.
Thank you so much indeed. It was amazing overview. Thanks a lot.